Welcome, everybody. My name's Warwick Strand. I'm the Director of Global Marketing at BVI. Today, BVI is hosting a short webinar where we introduce ISOPURE lens to the UK market. The importance of this is it's the first time BVI is actually serving the UK market directly with our IOLs. So not just ISOPURE, but also now BVI will be serving the whole UK market with our full portfolio, from fine vision, which everyone's very well knowledgeable about, to our monofocal lenses, MicroPure and Pod Eye. Today I'll be joined by Professor Oliver Findl, who will be talking about the technical features of ISOPURE, and also Professor Bilbao, who will be talking about the clinical outcomes over the last 18 months. ISOPURE sits at the heart of our portfolio of family of lenses. It is a premium monofocal, suitable for your cataract patients, that is designed to provide a level of intermediate vision without compromise on quality vision with the simplicity of a monofocal lens. Without pausing any longer, I'd like to introduce Professor Findl, who will now start the webinar and talk about the technical features of ISOPURE. Thank you.
So thank you, Warwick. Let me start with the presentation. I hope it's up. Here we go. So let's start with what is an EDOF lens, and I think that's quite a confusing term. And as you can see in the picture below, we talk about multifocal lenses, which is trifocal, bifocal, and segmental multifocal lenses, and then we talk about EDOF lenses, and there's a whole array of different lenses which we sort of count into that category. It's quite clear that diffractive and refractive multifocal optics generate more than a single focus, and we know that it has drawbacks, especially halos, to mention one. A real EDOF lens should actually elongate the focus for distance vision towards intermediate vision without actually having a second distinct focus. So the idea of extending the focus should eliminate halos. The problem is that by elongating the focus, you can obviously also lose some quality in the retinal image, and that may also limit its performance. So I think the new terms which I've come across in the last, let me say, weeks and months is monofocal plus IOL or enhanced monofocal IOLs. And this is really what we're talking about today. One of these new categories, whichever term we will actually use to coin it. So where does the word ISOPURE come from in this case, and what did BVI and think about for this term? So it's ISO from the Greek meaning equal, and the idea being to describe a uniform increased defocus, and then pure actually defined as the hydrophobic glistening free material, which we already know from Physiol. It's as you can see here, based on the MicroPure, which has the material which we'll go into a little more detail later on. And at the below, you can actually see the from the instructions for use, the intended use, being a monofocal intraocular lens. So here we're not talking about a multifocal lens, but really a monofocal intraocular lens to be used in the capsular bag. So it's a premium monofocal IOL, or monofocal plus if you want to call it, to provide functional intermediate vision, ideally without compromise on quality of vision, at least from the perception of the patient. So we're trying to extend the vision range, and they use a polynomial complex surface design, and we'll come into that just in a second, across the full optic. I think that's also important. Extending the depth of focus and giving some functional intermediate vision at all pupil sizes and also lighting conditions. And at the bottom, you can see the concept of elongating that focus. So here you can actually see the so-called polynomial complex surface design, which is actually on the front and posterior, so anterior and posterior surface of the lens, inducing negative asphericity, especially towards the more periphery. So what you can see is that compared to the monofocal lens, the MicroPure as the, let me say, light blue, and then the violet line for the ISOPURE lens, you can see that until about 1.5 millimeter diameter, there's actually no difference. And then the ISOPURE actually starts to induce this slight negative asphericity. You can see this is using actually a slightly positive aspheric cornea, the ISO2 cornea, which is the one where most patients fit in. Now, please don't ask me to comment on that polynomial function because I'm not a mathematician. That's not my field. So what you can see here is the through focus NTF curves using again this this ISO2 spherical cornea. And you can see on the left side the monofocal lens with the 20 diopters, and on the right side the ISOPURE. And what you can see, and we're just looking at the, let me say, right side or positive side of the MTF, you can see that there is quite a widening of that MTF. So from that perspective, we should gain some, as we said, an elongated focus. And you can see that that is actually for 3 millimeter pupil, you can see that actually a plus of nearly 50% of that depth of focus is increased. So we still can maintain a high quality of distance vision. And on the right side, you can see the data from Pavel Sodulka, which he presented about a year ago on a small number of patients at that time. This is 6 months data. And what you can see is uncorrected distance visual acuity, very good. Corrected or best corrected distance visual acuity, even better, as you would expect. And then 80 centimeters uncorrected and distance corrected intermediate vision, also still very good. And then actually even at 66 centimeter, which we sort of call closer intermediate vision, we still have good unaided and distance corrected intermediate vision. Here, the actual defocus curve of all the patients together, and you can see you have actually 2.5 diopters of that defocus range, which is significantly more than what you would expect. Like we say, more than 1.5 diopters at 0.2 logMAR is what you would call, you know, an EDOF lens. So we're really actually in that realms of what you would call an EDOF lens, and even a little above that. And now looking at the high quality 20/20 distance vision and looking at contrast sensitivity. And what you can see here is monocular and binocular under photopic conditions, and even under mesopic conditions for monocular and binocular, really within the normal range. So very good contrast sensitivity in these patients. Now looking at pupil size dependency, which is obviously always a big topic. And you can see here for 3 millimeter, 3.75 millimeter, and 4.5 millimeter pupil, the MTFs. And you can see that's, you know, a pretty broad range, even for the, especially for the larger pupils, which really results in, as you can see here, in this pupil size nearly independent EDOF value. Here comparing that with the monofocal lens. And here comparing the MTF, again, across pupil sizes, here for the monofocal and then for the ISOPURE. So really very good MTF results across the board for different pupil sizes. Here looking now at the USAF targets. As you can see, left is the ISOPURE, right is the monofocal lens. And you can see distance, essentially no difference. And then here now looking at the different 0.3, 0.6, and 0.9 diopters defocus. And you can see here that there's always a better resolution of the ISOPURE. And even at 0.9, it's still a little better. You can hardly actually recognize the 4 and the 5 in the monofocal, but you can still have at least an idea of the 4 and the 5 in the ISOPURE lens. So a pretty good results even at this USA targets, which you know are pretty difficult targets to start with. Now, just a few words on the hydrophobic material, which is a material which has been around for quite a while by Findl. And obviously looking here now at glistenings, this is actually data also from the David Apple laboratory from Gerd Auffahrt in Germany, in Heidelberg. And you can see here the G-free material compared to hydrophilic and then the other hydrophobics. And you can see very good results. And here at the bottom, you can actually see the Findl in the center. And then lenses of two very, this is the Acrosoft on the right side and the sensor material on the left side, actually does very good in this in these models of heated lenses over time concerning glistenings. So really, we can see this essentially an uncompromised quality of vision, very similar to the monofocal lens. It uses all the available light energy. So because we're extending the range of focus, we're not dividing into different foci. So we're not using any diffractive technology or even refractive technology. And we maintain contrast sensitivity very comparable to the monofocal lens, as I showed you. The 20/20 distance vision, if you want, the high quality vision is also very similar to the monofocal, and the material we've already discussed being having a really good track record. Now, let me also show you the preloaded system. For those who don't know it, I may actually not show the entire videos, but just show you parts of it. So here you can see the lens is actually inside this box, which has a fluid in it, and then you actually dock the injector onto the box. You keep the plunger there for a few seconds. This can obviously be done by the nurse. And now the lens is actually already loaded. You remove that from the container, and you just check that the clip is on. Let me just skip that. That's a little slow. There's obviously, like always, things you need to be aware of. And you can then introduce BSS if you want to through that hole, and then viscoelastic will go in there. That's what most people will usually use. Let me skip that just to be, and here you can see the actual lens coming out of the injector. And I guess Rafael will also be showing, or maybe be showing the one or other video to illustrate that. Let me stop this video and just actually continue with this one. So again, the same steps. Now this is actually live. So we see that we take out the safety release and push the lens forward. These lens haptics, as you know, have a long track record with the Physiol lenses since many, many years. Very good centration. Also very little tilt. We've actually assessed that in a study a few years ago, looking at tilt and decentration using a Purkinje meter system. We've also published that, showing that the lens does very well. And then hydration, you can see the lens inside the eye. Here we go. So let me just skip this. So really, as I showed you, a non-diffractive system and design. So you don't need to have these discussions with patients if you want to use EDOF technology with diffractive lenses, because you know the issues about potential halos. The simplified implantation, which I just showed you, which is being used for the monofocal lens as well. And I think with that, I just, you know, essentially from my perspective, and we've started out a trial, so we're right in the middle of our trial, actually comparing the two lenses. From my perspective, really, I tend to, and we can discuss that later. The way I go about it is I use this as a monofocal lens, meaning I don't really tell the patient about any added value at that point. And that's obviously, that depends on how you have your setup and how you want to go about things. But really the nice thing is if you don't actually promise anything, but then really deliver, and especially we can also discuss that later, if you combine it with a little micromonovision of a half a diopter or so, patients really have some really good intermediate vision and sometimes even a very useful reading vision. And I think Rafael will show you some data on that. And so from my perspective, there's really no contraindications. I mean, here it says AMD grade, an advanced grade of AMD. Well, from my perspective, that's not even that is really a contraindication. So I think you don't really have to be worried about these things. Quite different from obviously all other, you know, multifocal technology where you really need to be aware of potential drawbacks. Now, obviously, if you have keratoconus or hyperopic LASIK or presby LASIK in these patients, then obviously this may not be the best patients for these kind of lenses in general. All right, and with that, I would like to close my talk, and I'll be very happy to take questions, Warwick, once these arise. Thank you very much. I can see one question, which is, what about blended vision? Did you do it? Is there a pupil limit? So I think we've, Rafael, you also alluded to that. I mean, to be honest, I haven't, in our study, we haven't done it yet because it's not part of the study, but essentially, I think, going for this half diopter, maybe even 0.7 diopter difference between eyes is something which is worthwhile if you want to give the patient maybe even some near vision under good lighting conditions. I think, as you said, Rafael, I think the important thing to tell patients and be quite straight about that is that they will, with very high probability, need reading glasses. And I always tell them you need reading glasses for reading, for very small print of fine work, and especially with poor lighting, like, essentially also with even multifocal technology, we know that. So I think if the patients are aware of that, and I can just talk about Vienna or Austria, the patients are quite happy to wear reading glasses at home. But what they want to do is they want to go out shopping, they want to go out to the coffee house and meet friends, which obviously now they can't, but let's say we're back to normal again, without having to need to take glasses with them. And I think, that's where these lenses, really kick in and do the job without the risks and the long discussions and then all the trouble of, dysphotopsia discussion. Rafael, what do you think?
Yes, exactly. This is what we say to the patients. With this lens, you're going to need glasses for the small print reading when you're sitting, when you're at home usually, but for the rest of the activities, you're going to get a proper continuous range of vision that will allow you to do many tasks without the need of glasses. And this is what it is most important. And on the other hand, these implanted patients are not going to have the secondary effects, that is the price all patients should pay for getting a complete freedom from glasses with a trifocal lens. And some patients are quite happy about avoiding these halos or certain loss of contrast sensitivity with diffractive lenses, instead of having a better general quality of vision in dim illumination and in the distance. Yes, I completely agree.
Yeah, I mean, this is also a question by Tobias Neuhan from Germany, asking when you mentioned, he essentially asks, with the ISOPURE, if you exactly hit target emetropia, do you actually get 1.0 or 20/20 visual acuity? And does the monofocal perform better than that? And I think what we both showed in the MTFs is, in the optical bench, the monofocal does a little better. It's minute, but to be honest, really in the clinical setting, it's very difficult to find that difference. What's your experience, Rafael?
Yes, it's exactly you. Patients are quite happy. In fact, most of our patients all of the patients were patients with cataract. So all of the patients were quite happy, but as elderly patients, sometimes it's difficult to get the difference between 0.95, speaking in decimal, or exactly 1. And although the MTF curves and the findings in the laboratory might be slightly inferior, I think clinically they're not relevant. And patients see as with a classic monofocal lens.
I think that's
a good point.
I'd like to add is also, that because you have a slightly broader defocus curve, as you've also shown, not only do patients maybe win intermediate vision if you hit emetropia, but also what happens is, because our biometry is not perfect, our power calculation is not perfect. We all know that. So even if you have a patient who's a little off, plus 0.5 or minus 0.5, their unaided vision is still pretty good. And that's really what, these patients don't want to wear glasses for distance, usually. So I think from that perspective, the unaided vision usually is very good, and probably at least as good as with a monofocal. Yeah. Because you don't always hit exactly target. What do you think?
I think you're going to confirm in your study, comparing with a micro-pure, if there's a slight difference in the distance, but definitely the intermediate vision is better with this lens, and this provides patients with a greater intermediate vision, and I think a greater satisfaction. And this helps in the sensation patients give us with this lens. Something that I really like about this lens is a no surprise lens. You know, you may have patients who have a slightly better near vision or slightly better results in intermediate visions, but I haven't had any unhappy patients, and I have dozens of patients already implanted. In fact, I have to tell you that I had to do cataract surgery on my dad just before just a year ago, before March. And although I had implanted a multifocal lens in my mother's eyes a few years ago, my dad doesn't like halos and glare, and he's quite perfectionist. He's also a medical doctor. And I decided to implant an ISOPURE, and he's extremely happy with it. He spent the 3-4 months of the first confinement we had here in Madrid just after the surgery without any glasses, and he was doing quite well. The working computer, the Zoom webinars we were having with the family without the need of glasses, and that's a very close results that I can and feedback that I can give you. So, and yes, as I mentioned to you, is a no surprises lens, to be honest with you.
There's also a question by another Rafael asking, visual acuity is important, but at the end, patient satisfaction is key. Did you evaluate it? Now, I can just tell you for our study, we haven't evaluated that. And also the problem, as you know, with patient satisfaction is always you need very large trials with a lot of patients to really tease out any potential differences. Do you have any comments on that?
Yes, it is extremely difficult to get a significantly statistical difference in questionnaires. So you need large volumes of patients. But our impression is patients with this lens are satisfied as far as you explain to them what they're going to really have before their surgery, which is a little bit more than a monofocal lens regarding better intermediate vision, more glasses independence for many tasks, and absolutely no halos or glares compared to multifocal lenses. So general satisfaction is quite optimal, yes.
There's one question also by Alice. Is centration stable? Maybe I can take that one. I can just tell you for obviously stability and centration and tilt depend on the geometry of the lens, on the haptics, on the material. And I can just tell you for that lens, because we've done a trial on that, as I discussed or just briefly pointed out. I didn't show the slides now because I didn't think it was should be part of this presentation, but I actually could have probably included them. And actually we saw that centration was very good and tilt was very little and was also stable up to 1 year. So I think that's not really an issue with this platform. From my perspective.
Yes, and from our point of view, we have an extremely large experience with the micro F trifocal platform that we really love, and it's a very stable and with low PCO rates also. And we've been having the trifocal lens now for many years. I don't know, 6 or 7 years, and also with a monofocal micropure platform. So we were very happy about that.
Warwick, here's a question for you, I think, from Norbert, asking about the Toric version and when it's being launched.
Yes, so it's in development at the moment. Anyone that's familiar with our lenses, they'll notice that we have a different platform for our Toric lenses with a double C-loop. So it's a little bit more complex. It's in our development at the moment. So yes, it's in our plan. I'm not privileged to kind of give you exactly when, but hopefully as soon as we can. Yeah.
I know the companies always love these questions.
Put me on the spot.
Everybody wants a date, of course. and I think it's important because Toric lenses obviously we know at least a quarter of our patients potential Toric patients, and so it's always an issue, but I'm sure it will come out. Yeah. So there's also one question from Omar, whether it has added value in a diabetic patient. I mean, to be honest, I don't have, so in our study, we're not including diabetics. I think it really probably depends on, is this a patient with, macular edema? And then do they have added value? Probably little. But on the other hand, having said that, there's also not really any risk. And I think that's the point. Because I always I've often presented that at ESCRS, at symposia, or especially at workshops, that if you use multifocal technology, real multifocal technology, the one issue is that you may be implanting this into a patient who is 60, 65, who may be a diabetic, who may have early glaucoma, who may have some drusen. And you don't know, these patients have a life expectancy of another 30, 40 years nowadays. So there's, in a certain way, that's always a risk. And you always have to assess, is this patient going to have, for example, diabetic macular edema some way down the road? And then, of course, bifocal, trifocal technology may be really a drawback. But I think here the risk is low to nothing. I mean, I don't know, Rafael, what do you think? What's your...
Exactly what you think. This is a great advantage of this technology. I'm very aware because we also perform many cases with clear lens extraction with younger patients at the population we had for this list. And I'm very aware. I try not to use diffractive technology in patients who are at risk to have in the future, maybe, as you say, in 20, 30 years, severe macular problem, and this is a great technology for this patient because it's easy to explain to them that it is better to be less aggressive in the freedom from glasses and getting a technology that is better and safer, and that they will provide also quite good amount of spectacle independence. Not complete, but quite good against safety for the future. Yes.
Warwick, is it okay if I continue with the questions, or do you want to take over?
Yep, no, I'm happy for you to continue this one.
There's also a question which came in, which I think is an interesting one. Did you implant ISOPURE in one eye for patients who previously had a monofocal lens in the other eye, like the MicroPure? So essentially having this idea of having a classical monofocal lens in one eye and having this sort of, let me say, monofocal plus in the second eye. I mean, I have had experience with that, not now with the ISOPURE, but with other so-called monofocal plus.
Mm-hmm.
I think the risk is very low. The patients, report essentially, as we said, no dysphotopsia. So I don't see this issue because I was never a fan of mix and match, refractive, diffractive lens in one eye and the other eye, or monofocal and then a refractive in the other. I always disliked that because I thought the halos are different. The starbursts are different sizes, different intensities, and I don't want to mix that. But here you don't have this issue. So really, I don't see a problem with doing that. So if you have a patient who already has a monofocal in one eye, absolutely, I would say go ahead and use a monofocal plus in the second eye. What do you think, Rafael?
Yes, it's exactly the same experience. I have a very large experience with multifocal lenses, and I never use mix and match optical different strategies. I think brain management of the image they get from the eyes has to be quite similar to help in the neuro adaptation to the optical system. So I don't like it. Whereas with the ISOPURE and other monofocal lens, I haven't found any problem. And in fact, I have two patients who were implanted previously with a monofocal lens, and both of them had a previous myopic corneal treatment years ago, and they were quite happy with the ISOPURE. They were getting better intermediate vision with the ISOPURE than with the previous monofocal aspheric conventional lens they had in the other eye. So
I'll ask you now, because there's a question from Sigrid Frieglinger, whom you may know is the chair of the Munich clinic.
Mm-hmm.
And he asks which corneal and retinal diseases are a contraindication. And we've already spoken about retinal diseases that, really, it's probably not really a contraindication,
Mm-hmm.
because we spoke about diabetic macular edema. I mean, these patients may not have the added benefit. They may not have the added value, but I don't think they're a contraindication from my perspective. But now we were speaking about corneal, you spoke about
Mm-hmm.
But what about, we discussed that previously, the hyperopic LASIK,
Mm-hmm.
keratoconus patients? How do you go about those, and what are your sort of thoughts?
Well, the impact of spherical aberration on visual quality is quite complex. I'm not a mathematician like you said before, but I have tried to read quite a lot during the last months, and you read many things that are often controversial, especially dealing with laboratory studies. So what it is true is when there's a large negative spherical aberration or large positive spherical aberration, you have an increase in the depth of focus that is, on the contrary, sustained with a certain decrease in the quality of the vision. So the good goal would be to obtain a kind of balance between both issues and to get a quite large depth of focus without deteriorating too much the quality of the vision. So I think increasing with these lenses in the average corneal spherical aberration is a good issue. If we have a previous myopic treated patient in the cornea with a positive spherical aberration, and you put a lens like the ISOPURE with a negative spherical aberration, you have a kind of balance. And in relatively recent papers, it has been shown that combining these surfaces with positive and negative spherical aberration, you can have a large increase in the depth of focus without deteriorating too much the visual quality. So I have done it in patients. I have implanted the lenses in patients previously done a myopic corneal treatment, but I wouldn't dare to do it in a patient previously treated with hyperopia with a previous corneal high negative spherical aberration, because this would mean to add another high negative spherical aberration and maybe getting to an extensive depth of focus, but not too good quality of vision.
I mean, I would also underline that, even though I have no experience with this lens in that setting, but I also think that, I mean, hyperopic LASIK is not that open, not often. We don't have that many patients with that situation anyhow to start with. But I think I would also, actually, there's one question here, which is a very different question, but it's interesting. What size capsulorhexis do you aim for when implanting ISOPURE? And now I think the answer is the standard, what you always use. That's the nice thing. You don't have to change anything. You don't have to, adapt your surgical technique or anything. You just go ahead. And you saw the injection system is very simple, straightforward. It's a no touch, so really preloaded system. And so from that perspective, I think it's really straightforward, and you don't really need to adapt anything concerning your surgical technique. There's one question by Tobias Neuhan. He's going about Fuchs dystrophy and ISOPURE. Well, that's a tough one. I mean, I think from my perspective, again, I haven't done any cornea guttata or Fuchs dystrophies patients. So we know that, we have these patients with cornea guttata who still have a completely compensated cornea, but the guttae really deteriorate the image. And I think it deteriorates the image with any lens, no matter which, monofocal and multifocal, definitely. So I think for me, these patients are real contraindications for using multifocal technology, classical multifocal technology. But to be honest, I would not have a problem using the ISOPURE in that patient. And if we need to do a DMEC later, we know that the outcomes are pretty good in these patients, and we can really achieve very good vision. We may not have the same kind of gain as we do in a healthy cornea, but I would not see any issues with that. What do you say, Rafa?
Absolutely. As you mentioned, you have to be very careful in using diffractive or refractive multifocal lenses in patients with gutta, and have to think and what is going to be the prognosis of this cornea in the future, because patients that are seeing through a cornea with guttata, I'm not speaking with Fuchs dystrophy, sometimes they have a loss of quality of vision that can be a problem with a diffractive trifocal lens. So yes, from this perspective, I think it's a good indication. I don't have any experience, as far as I remember, in any patient, but I don't think I would have any problem. In fact, if the patient is a contraindication for a multifocal lens implantation, I should explain and possibly implant an ISOPURE lens, yes.
I mean, this is Alice. She just mentioned that we didn't answer one of her questions. I'm sorry about that. She asked, what about the pupil limit? Is there a pupil limit from your perspective for using the ISOPURE? Now, I would say, just out of my gut feeling, and not gut feeling, actually showing the slides, of pupil size independence, I don't see an issue here. What do you think, Rafael?
Well, you see, with spherical aberration and pupil, we have two issues to consider. Normally, the aspheric increase in depth of focus is larger when the pupil is larger. So usually with smaller pupils, you may have less benefit if we consider strictly with a spherical aberration. But the thing is, with a smaller pupil, we have another advantage in the optical system of the eye. That is, we have the stenopeic effect of a small pupil. And as this lens, the ISOPURE has a very high negative power in the center of the lens, and this is increased, and the depth of focus is increased with a small pupil. You have this balance between the fact of having less effect with a small pupil regarding the spherical aberration, but better depth of focus related to the stenopeic effect. I don't know if I could explain you properly what I meant. My English is not perfect, sorry.
I think we showed in the slide, you know, that in this central 1.5 millimeters, essentially they're very, very similar, and only then the ISOPURE actually really kicks in. So really, with a small pupil of, let's say, 2 millimeters, 2.5, which do happen sometimes, the stenopeic effect is there, the small pupil effect, the pinhole effect is there, and we have that already, and that's going to help the patient
a lot. Yeah.
Pupil dilates, then you actually get that effect, and you keep it over the larger pupil. So I think, from my perspective, now a very question to you, Rafael, very personal. Did you use monovision in your father?
I did. -0.5 in one eye. Yes, right. yes. I think it's and we saw it when comparing binocular defocus curves. The range of unaided vision in the intermediate vision is larger with a binocular implant. So yes, I mean, there isn't a great difference, but I think the results are slightly better. Yeah.
Now I'll ask you a question about that, and that's always this question which comes up again and again. And I think there's a lot of there's two schools of thought. You know, this idea of dominant eye, non-dominant eye, dominant eye distance, and non-dominant eye for near. And obviously here we're not talking about near, we're talking about half a diopter, right? So it's very different. Do you actually discuss the patient? You know, do you actually ask about dominance in these cases, or do you just go ahead and just one eye distance, one eye -0.5?
I have a quite large experience with monovision, with blended vision, before my experience with multifocal lenses. And to be honest with you, the trick with classic monovision is doing it in patients that are good candidates for it. The eye to be chosen doesn't matter really. What you have to do is not doing a monovision in patients who have a poor binocularity, in patients who have a clear ocular dominance, because in these cases, if you leave one eye for the reading, the dominant will get all the vision, and this will not be a benefit for the patient. But in patients who have good binocularity, you have studies with good results, leaving the dominant eye for the distance, other studies with good results, leaving the dominant eye for the reading. As you all know, in the dominant, you have the sensitive and you have the motor dominance. So to be honest with you, I don't think there's a big problem. And in fact, also, when you have patients with cataract, it is very, very difficult to disclose what was the dominant eye and what is so if you think patients have good binocularity, they have having it for the rest of their lives, it doesn't matter. And on top of that, if you only leave a small amount, such as a half a diopter, it doesn't make any difference.
We only have 1 minute left. And for that 1 minute, we have one sort of question which covers sort of many things, because actually they were also in the chat. The idea is, you know, should we use this routinely in all cataract patients, or is there any disadvantage compared to monofocal lenses, or will the isofocal, or the ISOPURE, as it says isofocal, actually replace the monofocal lens? So that's a question. Obviously, we don't know what the future will bring, but I can just say from my perspective, monofocal plus lenses of this kind of quality as we're talking about here, I believe can be used essentially like a monofocal lens. I don't think you have to worry. Is that, and maybe we spoke about maybe, you know, the hyperopic LASIK, some, you know, some reasons, but they're very rare. What do you think, Rafael? Are we going to replace?
I completely agree with you, Oliver. I think they're going to substitute, and all the trick will be to see what is the position of the brand of Physiol, what is going to be the price, what is going to be the difference of the price, and the fact that in some circumstances, in some countries, with some insurance company, this is going to be covered or not. So it's going to be more of a practical commercial issue than a medical issue. If I had to choose, I would implant this technology in all my monofocal patients from now on.
And exactly here we come back to Warwick. So you have to I don't know, it's different from country to country, and that's obviously
exactly.
which will develop and evolve, I guess. I think from my perspective, I'm done. I think we've answered nearly all questions. And yeah, so I'll hand back to you, Warwick.
Thank you. And as I said earlier, thank you both of you. Your presentations have been brilliant. And more so, you've been brilliant at helping us with answering these questions. It's been a really good discussion, which actually has taken us something like 20 minutes on the Q&A. So really, really good questions from the audience and great responses there. And also, I'd like to just say thank you for everyone that's tuned in to watch. Obviously, we had this as a launch for the UK. I've just looked at the participant list, and actually we've got quite a wide international. So from many, many markets, so everyone that's joined us today, thank you very much. And thank you, everyone. Bye-bye.
Thank you very much. Bye-bye.